All right. Well, welcome everybody. Excited to have you all join us for the March 5th, 2025 Fellows Virtual Tumor Board hosted by the AHNS. This month's going to be a lot of fun. This is workup and management strategies and revision and non-localizing parathyroid surgery. Extremely challenging part of the specialty. Special thanks to Dr. Alan Ho and the Endocrine section for putting this one together. Dr. Ho is a professor and the director of head and neck cancer program out at Cedars-Sinai in Los Angeles. Before I turn it over to Alan, just a brief reminder, we'll try and stick to about 20 minutes per case today. And please submit your questions in the chat box between myself and Alan. We'll try and bring those to the group for discussion. Also, if you're not actively speaking, do your best to try and mute yourself just to minimize background noise. But really excited for today's session. Appreciate you guys being a part of this. So Alan, take it away.
Great. Thanks a lot, Michael. Welcome, everyone. I'm Alan Ho. I'm happy to moderate today's topic today, which is workup and management strategies and revision and non-localizing parathyroid surgery. This is the kind of case that since chills down many of fellows' spine, never has such a case existed that should be so easy that may turn out to be so hard. But today we'll have some excellent cases that you probably will pick up a number of pearls from, thanks to many of our fellows and the hard work they put in. I just wanted to very quickly introduce first our expert discussants, and then we'll go straight to a case. The first person I want to introduce is Russ Smith. He's the adjunct professor at Florida State University and the oncology medical director at HCA Florida Jacksonville. Russ has been around quite a while. He's really an international expert in ultrasound. He also did his residency at University of Missouri, his fellowship at University of Iowa, and we're really, really happy to have him. Thanks again, Russ. Okay. Then we also have Jeremy Freeman from the University of Toronto, a very distinguished professor in the Department of Otolaryngology. He's the Temi Latner Dynacare Chair in Head and Neck Oncology. He completed his residency at Toronto, did his fellowship as a McLaughlin Fellow at the Royal Marsden Hospital in London. He is, I didn't know this, even though I've worked with him for some time, appointed to the Order of Ontario. This is reserved for exceptional individuals, quote unquote, who have made a lasting impact on the province and the great country of Canada. So thank you, Jeremy, for gracing us with your presence. All right, so let's go ahead and get started. I'm going to unshare, and then Caitlin, if you could go ahead and discuss your case. I've titled it "In the Case of an Unexceptional PTH Drop." Go ahead.
Okay, everyone. I'm Caitlin Olson, and I'm the current fellow at Loma Linda University. And my faculty person today is faculty mentor is Paul Walker. So this is the case. It's the one that always sticks into my head as one of the biggest learning cases. It was a 64-year-old female with a past medical history of essential hypertension, spontaneous subarachnoid hemorrhage, ischemic stroke in 2023, diagnosed osteoporosis, and then also nephrolithiasis, and then the remainder of her history as listed. I have her trends and her calciums. Interesting, and her PTHs. Interestingly enough, she was initially diagnosed with osteopenia in 2013, which sort of corresponds to this original hypercalcemia that was noted. And then she was diagnosed with true hypercalcemia in 2021, which corresponds, I don't know if you can see my cursor, but it corresponds with the PTH, which was noted to be elevated in 2021.
We can see your cursor.
Okay, perfect. Thanks. So on her initial presentation to us in clinic, she came with a diagnosis of hypercalcemia and hyperparathyroidism, initially diagnosed in 2021. The osteopenia and osteoporosis as discussed, and then her most recent DEXA was in 2024. She initially saw us in mid-2024. The T-scores as listed. She had a history of nephrolithiasis with a calcium type stone. Last stone passed in 2023. Her creatinine clearance, her vitamin D, and the C-telopeptide, which was a new one for me. It's something they use for osteoporosis to determine whether it's related to bone resorption or low remodeling, was normal. And it's supposedly or reportedly elevated in hyperparathyroidism. She reported a history of fatigue, brain fog, muscle weakness, constipation, reflux, new lower extremity bone pain, a 3-month history of dysphonia and dysphagia from her prior stroke. She was currently taking 3 to 4 times a day for her reflux symptoms. Denied nausea, excessive vitamin D intake, use of diuretics, lithium, and thiazides. She was diagnosed in 2021, and then since that time in 2022, she underwent parathyroid ultrasound. They saw some subcentimeter nodules in the left, and supposedly one nodule in the isthmus that they said TR5, but they later call it a TR4, but no parathyroids visualized. And then in 2023, she had a repeat scan with multiple subcentimeter nodules and no visualized parathyroids. So in clinic that day, due to her history of dysphonia, we did a flexible laryngoscopy, suggested LPR. We asked her to stop her Tums use and recommended adjuncts for her reflux. We sent her for confirmatory labs. They confirmed elevated calcium and PTH. And of note, normal renal function, also normal MAG, normal phos, and normal vitamin D. We sent her for nuclear med testing. This is the protocol at Loma Linda now. So we have the sestamibi as well as the fused SPECT, which suggested a adenoma of the mid-left thyroid region. We also sent her for an ultrasound, another repeat parathyroid ultrasound, again with the scattered subcentimeter nodules, nothing TR3 or TR3 and TR4, but no corroborating parathyroid adenoma either. There was the 6-centimeter lesion noted posterior inferior to the contralateral on the right side, but more suggestive of a lymph node than the parathyroid adenoma.
Aylin, in your experience so far at your institution, how sensitive, how accurate do you find your imaging to be?
I wouldn't put a number on it, and in part because we're in San Bernardino County, so it's the largest county in the contiguous United States, and so we actually are a huge catchment of people. We get them from the high desert all the way down to Marietta Way, which is closer to San Diego. And I can't say that they all come with the same imaging. I'll say that my rule of thumb personally is that I will believe them until I take it with a grain of salt. I will use as a guideline, and then when it doesn't work, then I'm not surprised. Let's put it that way.
Very good. Very good philosophy. Carry on.
Yeah. So
You got the Zoom thing tonight, right?
Yeah, it's
Okay. Yeah, just go through that. I'll go see you share.
it's
Oops, sorry.
okay, so we take her to the OR. Her baseline PTH was 133.1. It's a good start. We look on the left side as recommended by the nuclear medicine testing. We find a grossly enlarged left superior parathyroid. We excise it, we send it for frozen, and then we find a left inferior. I tend now, from having been burnt a lot of times, that I will always look for the two on the same side that I'm looking, always. And then I did this in the order of how I proceeded to get the results back, based on the timeline, because I think that is the easiest way to look at it in my brain. So we start the clock as soon as we excise it. We also have a lot of trainees, so we kind of pat ourselves on the back. We found a really large adenoma. It corresponds with the imaging, and we've probably started closing at this point. While waiting. So at 11:43 a.m., we get the first parathyroid. It's 58. Technically, it meets criteria. So then we really start to pat ourselves on the back. But we will never finish out without doing 2 confirmatory labs. So the second lab comes back. It's 54.8. This is when I will start to get a little suspicious. So I asked for actually a fourth 30-minute lab at this point, because I have learned that it's easier to ask at this point than to wait and decide later and then have to wait the other 15 minutes. Our pathologist is right across the hallway at this surgery center. So he comes back with parathyroid adenoma from the left superior parathyroid at 750 milligrams, which is great. Again, things are going our direction, except I'm not totally happy with the labs.
Right. So, Kate, let me stop you there. So, Russ, can we ask your opinion on what you would do in this scenario? It looks like Caitlin has met Miami criteria. There's a big, honking, obvious parathyroid adenoma. Is this something that concerns you?
Yes.
And why? Yeah.
So even from a baseline presentation perspective, I would be concerned. Anytime I see patients that have relatively low elevations of their calcium as well as marginally elevated PTHs, I'm kind of suspicious that they have multi-gland disease from the beginning before I ever take them to the OR, independent of what their localization shows. So I'm always a bit suspicious on these patients that present with marginally abnormal labs.
When you talk about this, like you're talking about like a four-gland hyperplasia picture, which
that are just even double adenomas, multi-gland disease. When patients come in and they have classic symptoms, classic presentation, their calcium's 11.9, their PTH is 175. Those patients, I think, truly likely do have a single adenoma. It's when these labs are a little bit less dramatic, has been my experience, that these patients end up with multiple glands being affected.
Right.
So I would have been suspicious even from the presentation that we may be facing more than one abnormal gland. And my criteria is that I like it to be less than 40. There was a nice paper that came out of Wisconsin that showed that if your last PTH during an exploration is above 40, that your recurrence rate's about 10%. And so in my mind, whenever this is that high, I typically don't even draw another PTH. I just go ahead and do a four-gland exploration because I'll be done sooner than I'll get all my labs back.
very wise, very wise. Okay, thank you, Russ. Caitlin, go ahead.
Okay, as Dr. Smith said, our third lab
Sorry,
also continues.
Caitlin, can I make a comment?
Sure.
I was muted, so I'm not being rude, I hope. In your imaging, I thought I caught a glimpse of a contralateral area that was lighting up. Am I wrong? Right there on your lower,
Yeah.
on your,
You're not.
on your-
Yeah, not wrong. I agree too, like looking back on it, but I think Dr. Ho had mentioned this too, is that sometimes these look faint to me and yet they're only calling one side.
and
So
on the panel of 4, the right lower one showed a bit of uptake on the contralateral side there. I thought I would be suspicious of that. That's one comment. And the other comment, two other comments I'd like to make is that I think we should all be doing our own, and Russ will agree with me, our own ultrasound. Because I can count numerous occasions where the imagers sent us quite erroneous interpretations of ultrasound. And I don't know, I haven't seen your hard copy, but I would like to see that hard copy to see if there's another adenoma on the other side. And one question I have of you is, why did you do a frozen section?
we always do frozen for confirmation. And then depending on the pathologist, they'll also tell us adenoma versus hypercellular sometimes as well.
I thought it's impossible to tell hyperplasia from adenoma.
That's what you would think, but one of our pathologists, he rarely calls an adenoma on frozen, but sometimes he will if it's something that you have the adenoma and then you have normal tissue that's sort of squished to the side. And so as long as that normal is there in addition to the adenoma, he will call it.
Because we're always arguing with our pathologists
Yeah,
and give me a break. All I can tell you is it's parathyroid tissue.
yeah.
Well, Melinda just has very bold pathologists. That's okay.
Dr. Sokol is a very bold pathologist.
Or advanced or smarter.
Excellent points by Jeremy. If feasible, try to do your own ultrasounds. It's not always easy, and it's something our field should continue to do more of. Sometimes I just have my residents try to do an ultrasound intra-op right before.
Okay. Will,
Go
hit pause.
ahead.
Okay. So as noted, we plateaued, and it's on my confirmatory because I've been taught to do the fourth one too occasionally if you're it usually makes more sense in a much higher starting PTH, because then you're talking about slow metabolizers that sometimes it will help and just make you sleep a little better at night. So at this point, we know we need to do a 4-gland. We have a lot of trainees, so we are probably closed by this point, and we were in this case. So reopen the incision, explore the right side. At this point, as Dr. Smith surmised, we did have a grossly enlarged right superior parathyroid, was excised, sent for frozen, a normal peri and right inferior parathyroid, and frozen pathology with, as you know, as our Dr. Sokol, he called it hypercellular, because as he writes here, no definite normal gland seen to diagnose adenoma. That's how he does it. And these were our confirmatory labs. 10 minutes was 15. 15 was 12.9, and then 20 minutes was 12. So that was it. A 1 hour post-op, the PTH was 7.5, our calcium was 2.4. Our protocol, we used to keep with a low, I think a PTH lower than 10, but now we're pretty, I would say laissez-faire, but we are repleting with calcium and Rocaltrol based, it's a sliding scale based on your PTH level. So we send them out. We will usually keep them if they're under 5, or definitely if they bottom out, or clearly in stage renal, or someone who's at significant high risk of hungry bone, we keep them as well. So post-op, this was the final pathology. A here is the left superior that was consistent with the parathyroid adenoma with oncocytic features. And then the right superior was also an enlarged cellular parathyroid gland. 1 week post-op, PTH of 12, calcium 2.4, 1 month, 34.5, calcium 2.4. And then she just had her 3-month 2 days ago, and her PTH was constant, 31.7, and calcium's 2.4. And that's it.
Caitlin, I am bracing myself for your answer, but my question is, did the patient's brain fog, muscle pain, and fatigue resolve?
You know, I actually don't know the answer to that. I didn't see her post-op, and I did
Is Paul
see
Walker on? Might he have an answer? I'm always curious about these patients that want the surgery.
She's actually not my patient either, but I
Oh.
assume if we gave her methylene blue, she's probably better now. That's the new hot health thing.
Okay.
Can I just ask a question? I'm terrible at math, and we use SI units rather than your units because we're north of the 49th parallel. And as my poor math tells me that you had a 60% drop in your PTH. So would anybody fault you for stopping right there and then?
Probably not, except for this was a case with our chair, Dr. Simmental, and as he said, you know, I don't want to come back in a couple months to do the revision, so will you look on the other side?
Right, but by all standards, by our standard, I mean,
Yeah.
50% used to be the gold standard.
Yeah.
And people became disenamored with that, and then said a 60% drop, which you accomplished, but nonetheless, you had a contralateral lesion. I mean, that was fantastic work, I would say, for the patient and yourselves, but still, it still adheres to code, but dropped 60%.
That is a good question because, you know, there is pathology on the opposite side. How long does it take for that to manifest? Will it ever manifest? So I don't know. I think there's a large handful of people who would have gotten the 58 and been fine with it. It's been in my limited knowledge that like I also expect a continued drop. So the plateau itself to me is pretty much an interesting, like I don't get nervous, but I definitely get that feeling of like, oh, I gotta go back in and look on the other side if I haven't already done a fork land, like if it plateaus. And you'll get this in the, especially with the much higher PTHs as well. Like sometimes you will take out that first one and then it'll plateau. And then you have to, even if you have 3 normal looking other glands, that like I'll still go look for the one that may look slightly abnormal because the plateau is what is always the kicker for me that I'll keep looking because I do want it to have a continuous drop. And I don't know if there's data to that, but it's been my limited experience that that's what I'm
Since we
looking
have
for.
such a rich reservoir of experts here, I'm actually I'll agree with Russ what he said about the unexceptional drop. Could I ask Michael Singer what he would have done in this location? Michael, how would you answer Jeremy's question? Would you have actually closed with that number in the 40s and 50s?
Yeah, I mean, the answer is no, I wouldn't have. This is there's a constant debate about um, where the number should get to so that you're not doing unnecessarily bilateral or contralateral dissection versus cure, right? That's really what you're balancing. I can tell you in my practice, I've moved from, as Jeremy said, 50% at 10 minutes, then 50% into the normal range. And now I've gotten to 50% in less than 40. And the other thing, and this is to, I think, Caitlin's point, is to me, it's the plateau, but it's really once you see a change in the slope, that needs to make you nervous. As soon as I see that, once you saw that's now your drop off was very significant, right? In terms of the slope, in the sense that it went really plateaued. But once I see that slope change, immediately that says to me, hey, you need to be concerned about it. I don't think what Jeremy is saying is wrong. But as Dr. Simmental said, like, I think always the first operation is your best opportunity to cure the patient. And so I'm willing to wait those extra few minutes to make sure that the patient's cured versus saying, oh, we'll close up, worst comes to worst, so we have to come back.
I would also hearken back to the original scan, which may, if it was read as possibility of adenoma on the other side, my threshold for going to the other side would have been quite low.
I think that will lead to a question I'm sure we'll talk about at some point is like everyone's preference for scan. Dr. Ho brought this up earlier in an email to me about like, what is your nuclear med protocol? Ours is actually really interesting because it's up to the discretion of the nuclear med guys. And so they will do a dual tracer. So they'll do the sestamibi, and then if they determine it will help them, they'll do the pertechnetate too, the technetium pertechnetate, which picks up for those, maybe for some of the fellows who don't know, but like it picks up the thyroid tissue. And so then you use that as a negative to overlay it on your system EB, which picks up both thyroid and parathyroid. And then the negative will cancel out your thyroid to sort of confirm adenoma. And then they will additionally put it on the SPECT. But that is only for patients in our system that go to Loma Linda. And as I said, the majority of our patients come from like a high desert or elsewhere. And I think usually at best I get a sestami, or we get a sestamibi scan.
Got it. In the interest of time, we're going to move on. We have, I think, other scans that we'll look at, and we can further discuss this SPECT CT dilemma. But let's move on to our next case. I believe it's with Alexa and Merrick coming from Emory. Thank you again, Caitlin. Great case.
So, hi, I'm Alexa Robbins. I'm the current endocrine head and neck fellow at Emory under Dr. Sieblick, and I will be presenting one of Dr. Sieblick's cases from about a year ago. So, This is a patient, a 69-year-old. She had a past medical history of bipolar disorder, neurocognitive decline, and a long-standing history of hypercalcemia and hyperparathyroidism, and a lot of social determinants of health that made it difficult for her to keep regular follow-up and get regular medical care, which contributed to her course. So, starting in about August of 2020, at another hospital, she was admitted for diverticulitis and was found to be hypercalcemic. This prompted her to be referred to a general surgeon who got a workup of a nuclear medicine parathyroid scan. And at that time, that nuclear medicine scan had no evidence of parathyroid adenoma or hyperplasia. And again, these are just reports because it's outside records, so I don't have the images for these outside records. In September, she went to the OR with this general surgeon who did an exploration, was unable to find an adenoma, but did do a hemithyroidectomy. His plan was then to have her come back. So he had her come back in October and he got a CT scan. The CT scan said it was a CT neck with and without contrast. It didn't really state if it was 4D CT protocol or not. And at that time, there was a nodular lesion in the left thyroid bed and a lesion in the left parapharyngeal space. And they said, was this a lymph node or an adenoma? Unfortunately, she was lost to follow-up for several years, and then she re-presented to an outside ENT in about 2023. She got some more workup and scans. She had a nuclear medicine scan in June of 2023, which showed some subtle uptake in the left thyroid bed, and then a CT neck with contrast. I don't believe there was any 4D CT protocol with this, and had an unchanged 1.1 centimeter nodule just inferior to the left thyroid bed. Again, she was lost to follow-up, and then she presented to an outside hospital in March of 2024, hypercalcemic. And because she had so many issues with, kind of keeping appointments and with the hypercalcemia, they decided to do an inpatient parathyroidectomy. And this surgeon attempted a left parathyroidectomy, but per operative reports, it was a really scarred field and difficult, ended up complicated by a pharyngotomy in the left piriform sinus that was repaired at the time, and no parathyroid adenoma was found. Then in April of 2024, she went back to the hospital because she started developing a pharyngocutaneous fistula and had a neck abscess and multiple electrolyte imbalances. And at this time, they decided to transfer her care to Emory.
So Alexa, hold on for just a second. So Russ, could I ask you a question as our discussant? How often these days are you performing hemithyroidectomies when looking for parathyroids? Is this a common practice that you endorse still?
No. I do all my own ultrasounds, as Jeremy had stated. It's a very important part of, I think, being best informed about what you may find intraoperatively. And if a patient has a completely normal thyroid lobe and I have done a failed exploration, I won't take that lobe out because the ultrasound is very sensitive. So if there's any intrathyroidal lesion, you're going to know about it based upon your pre-op ultrasound. Now, if someone has had an exploration and there's an intrathyroidal pathology and I haven't found things, that would change my perspective. And I think even now we're becoming sophisticated enough with ultrasound that even preoperatively we ultrasound patients and things look like thyroid nodules and sometimes things look like parathyroid glands within the thyroid gland. So you can see the polar blood supply. But I wouldn't routinely do it unless there was some intrathyroidal pathology that I couldn't exclude. Negative ultrasound, I would never do a lobe.
And if you're so confident with your ultrasounds, are you getting any other scans as a routine measure? Like looking at this scan, this is very familiar with what we see in our institution, no evidence of this, subtle that. Are you getting any of those other scans?
So I think that's a great discussion point, and I'm glad it came up again. So everyone gets an ultrasound, so they want to make sure, do they have concurrent thyroid disease with their parathyroid problem? I want to try to localize the parathyroid adenoma. I think an important teaching point about sestamibi scans is that unless your adenoma is greater than 500 milligrams, which makes it reasonably sized, you have a pretty high incidence of negative sestamibis. So if I've done an ultrasound and I don't see something, I think it's unlikely the sestamibi is going to help. There may be something hidden in the mediastinum, and if that's the case, I'm going to get a CT to figure out where it is anyway. So I've kind of eliminated sestamibi as part of my protocol. So I typically start with an ultrasound. If I see something, great. If I don't see something, then I'll go to a phased CT scan to look for something smaller or something that may be hidden that I just can't see with the ultrasound. If everything's negative, I may get a sestamibi just to kind of be complete before I go explore, just to give me a little more information. But that's kind of the approach I use for my imaging preoperatively.
Excellent. Okay, Alexa, proceed. Thank you.
Okay, so when she presented to Emory, she had, and here's the CT scan showing this fistula. She had significant erythema, two fistula tracts. On her flexible laryngoscopy, she had a hypomobile left vocal cord. And then her PTH on presentation was 825 and her calcium was 11.6. So the next day after arrival, Dr. Seabug and team took her just for a neck washout. So did a DLB, neck IND, and there was a 3 centimeter linear injury to the left piriform sinus and just a lot of granulation and scar and inflammation to make primary closure really not possible. So a salivary stent was placed for diversion, a Penrose was placed, a pressure dressing, she was placed on Robenal, and the parathyroidectomy was delayed. And during this time of delay and just letting her be on antibiotics and heal, further imaging was ordered for localization. And I kind of intersperse some discussion points in this talk, and we can either, I know we sort of just kind of talked about this, so we can move past it or discussed again, but what imaging modalities are preferred in revision cases for people?
Good question. Let's ask Jeremy. Jeremy, in a tough case like this, very challenging, do you go to any particular scan? What's in your toolbox?
Yeah, for the revision ones, just before we go there, there was something in your last slide. They said they thought there was a parathyroid that they took out.
In all the other institutions, they never found parathyroids.
Okay, so histologically, there was never a proven parathyroid.
Correct.
That's correct. Okay, sorry. Okay, these revision ones, I just hit them with the book. I go with a sestamibi, a SPECT CT, conventional CT 4D usually, and see what I've got with that.
Okay, excellent. Yeah, it was, you had another discussion point too, right, Alexa, or was that the main one?
At the end, we have some discussion.
In that case, let me ask Mary, who probably knows this case so intimately well. Could I ask what your practice is in these cases?
Well, to echo Russ, I repeat my own surgeon-performed ultrasound. And I'm not going to give away this case at all, but this was a case incredibly supportive of surgeons looking themselves. But I just like Dr. Freeman said, I kind of throw the book at them. I get a 4D CT, which of course is non-functional. It's not a functional scan, it's an anatomic scan. I do get a functional scan. I do get a sestamibi just in case it shows something. And you had a good question for the last discussants. I'm not always enamored of the accuracy and even the technique done for sestamibis. I think that the technique is tricky and that can lead to
Ambiguity.
Yes, thank you. Thank you. So, and I don't even look at the outside ultrasounds. I just do an ultrasound myself. And so I think a revision case like this really does need to have every possible imaging modality because this is a little bit of a rescue case. And also, I do want to make the point where this case is not meant to be critical of our preceding surgeons. I think especially the one who was operated with the really high calcium. I think it was somewhat heroic, but that surgeon was hampered by not having the skills of doing their own ultrasound. And so I really feel for the two prior teams. So this case is not meant to criticize anybody.
Alan, can I just make a brief comment? And this is just to reemphasize what Mary just said and what Jeremy just said. I do think it's just critical for the fellows to be aware that in general, reoperative parathyroidectomy is really, it's a distinct entity from primary surgery. And one of the ways that it is most clearly a distinct surgery and a distinct entity is that in most instances, most endocrine surgeons will say that you really should only be doing reoperative cases when you have a clear target. Now, that's not absolute, as we'll get to in the next case, but I just think it is important to understand that that reoperative surgery is not just like, yeah, there'll be some extra scar tissue. It really is important, I think, to think about it as a totally different kind of paradigm than we think about in primary parathyroid surgery.
Well put.
Can I just ask one simple question? This was a bipolar individual. Was she on lithium at any point?
Not that we saw in her records, but that's a really good point.
Just curious.
Yeah, not that we saw in her records at transfer.
Not that it would change anything.
All right, Alexa, let's proceed and we'll get to the end of find the conclusion, the surgical triumph. Yes, go ahead.
So our team ordered a 4D CT scan, and these are the images here, and it had a very classic hyper-enhancing mass posterior to the left carotid, and that's seen right here, measured, measuring 1.7 by 0.7, and very classic avid arterial enhancement and then rapid washout, consistent with the parathyroid adenoma, and this is that right here. And you can sort of see the resolving fistula. So she was taken to the OR on the 29th. This is roughly 10 days after her presentation for a directed left parathyroidectomy. And as Dr. Seeblick mentioned before, Dr. Seeblick did a pre-incision ultrasound, which really confirmed this retrocarotid mass and also used the ultrasound intraoperatively to find this mass through scar tissue, and identified a 2 by 1 centimeter parathyroid adenoma posterior to the left common carotid at the thoracic inlet. This was also confirmed on frozen. That's sort of the protocol at our institution as well. And her PTH went from 829 to 154. And then on this next slide, so Dr. Seeblick, as she mentioned, did a directed approach. So this is the original incision, and then where the new incision was sort of directed by the ultrasound of where to place it and to keep it out of the operative field of the fistula and the previous surgeries. So for conclusion, her fistula resolved with iodoform packing and conservative measures. She was able to get the salivary stent removed and a gastrographin that didn't show a leak. She was transitioned to a regular diet. Her post-op PTH decreased to 22, and she was discharged to her personal care home in June of 2024. Unfortunately, as aforementioned, we haven't been able to follow up with her because she hasn't made any of her follow-up appointments thus far. But some other discussion points, and again, we don't have to use these, we can do something else, but what is the preferred surgical approach in primary cases, and then what is the preferred surgical approach in revision cases for people?
Yeah, good question. Russ, do you with this merge them together, do you ever deviate from the standard, midline incision in your case, in your surgeries?
Not for primary cases. I think in revision cases, you do have to start being creative, especially if you have a localized target, to try to minimize the amount of effort you put going through old scar tissue. Sometimes you can't help it. So if you have something that's setting behind the esophagus and somebody's already explored that side, but that's where you have to go, you have to go. But I think in this case, as Mary pointed out, I suspect Mary went lateral to the jug, lateral to the carotid, didn't even really get back into the central neck and kind of stayed in a lateral plane. And I think that's a really nice way to do these cases to simplify, the morbidity. Because this patient, I think, going back into that central neck to try to find an adenoma, the risk of a recurrent nerve injury starts to skyrocket. And so I applaud her for taking a little more creative approach to get to this.
Great.
Just
all right.
One more question. Alexa, do you know what happened to her bipolar state?
It did not improve much. Okay. Yeah.
Dr. Freeman, I said exactly the same thing. What if all of her mental health issues go away? Unfortunately, they did not.
One can only hope.
Great. So the take-home points for this case, number 1, do your own ultrasound, and number 2, send all of your bipolar fistulized patients to Emory. Okay, great. Let's go on to, I'm just kidding. Just don't. Mary would kill me. Please don't send your revision cases to her. Okay, let's move on to our third case, Jake and Michael. Dr. Singer, go ahead, Jake. Thank you.
All right, my name is Jake Sims. I'm from Henry Ford Health here in Detroit. I want to thank you for the opportunity to present. And I want to thank my mentor, Dr. Michael Singer. This is an 84-year-old female that presented with persistent hyperparathyroidism after 2 previous parathyroid surgeries. Sorry, I lost my slides. 1 second. There we go. Past medical history, she has Hashimoto's thyroiditis, OSA, and hypertension. Physical exam-wise, the only thing notable was a well-healed midline cervical incision. So her treatment history in early 2000s, she had the diagnosis of primary hyperparathyroidism. And then in 2005 or 6, she had a parathyroidectomy that was performed at an outside hospital. It was reported that a single gland was removed and that this was confirmed pathologically. It was unknown which gland, and unfortunately, there was no pathology or operative reports available for us. She did end up having persistent hypercalcemia after surgery. She did have fluctuation of her calcium levels over the years. She denied any history of kidney stones. She reported good bone density, but she did undergo a back surgery several years prior to seeing us and was told that her bone density was poor. And then in 2019, she had an attempted reoperative parathyroidectomy with the same outside surgeon. At this point in time, she underwent bilateral exploration, and the surgeon used radio guidance. And again, reported that there was a left inferior parathyroid gland that was removed and confirmed pathologically. There was also a reported drop in the intraoperative PTH levels. And again, unfortunately, there was no pathology or operative reports available for us to review. And unfortunately for her, she had persistent hypercalcemia after this as well. And then in the previous 6 months prior to presenting to Dr. Singer, which was at the end of 2024, she had worsening systemic symptoms. She presented with her daughters, and they were just complaining of pretty severe weakness, loss of appetite. Really, the cognitive issues, I think, were the main concern, as well as pretty significant mood changes. And the day before she saw us, she had this nuclear medicine scan, and these are the static images, and I'll just roll through this.
Attention visitors, patient visiting hours will end in 15 minutes at 8 p.m. Please plan to leave the hospital by that time. Thank you for your cooperation.
Okay, sorry for the overhead, but there was nothing identified there. And then we did an in-office ultrasound on the 20th when she presented to us, and there was no obvious gland that was identified. She did have a hypoechoic lesion in the superior aspect of the left thyroid lobe, but this was not definitive for Dr. Singer. And then the labs from that day, she had a PTH of 108, normal vitamin D. Her corrected calcium was just a little bit high at 10.5. So at this point, she's had 2 previous parathyroid surgeries with removal of 2 parathyroid glands. There's been no operative reports or pathology for confirmation of what exactly was done or what was removed. And she's had this ultrasound in office as well as a nuclear medicine scan that does not have a clear gland identified. Just wanted to ask if anybody would do any additional labs or imaging.
Let me ask Russ, challenging case, challenging situation. Would you do any other workup at this point?
Well, I feel very dissatisfied that I haven't seen an ultrasound image of a parathyroid gland yet tonight, but it doesn't sound like this case you could see one. Michael, these were ultrasounds you did with your expertise. You absolutely can't see anything.
There was nothing that I saw certainly in any way clearly. And trust me, I was looking hard because, like I said, pre-op case, and I didn't see anything.
And you do not have any your thoughts about this little thyroid nodule? Is it something that you consider as part of the possibilities?
It was this very small hypoechoic lesion that was posterior to the superior aspect of the gland. It wasn't intrathyroidal.
Okay.
Can I make one suggestion? Can you hear me?
Yeah, go ahead, Jeremy.
Yes.
One thing that I've toyed with over the years that I found quite useful, it can be done in the office, would be jugular venous sampling with ultrasound control in the office for PTH. Although it doesn't give you exact localization, it does give you a side. Because oftentimes when I was faced with this, I would get a distinct difference one side to the other. just for your consideration.
And Jeremy, I think that's a great point. I've actually been lazy and I just send the patients to the neurointerventional radiologist, and it's really easy for them to do a vein stick, and then they just run a catheter, and I have them map it out, and I have them take 3 sites on each side of the IJ on each side of the neck, and then I have them run the brachiocephalic veins as well. So that way you even catch the mediastinal differential. So that's the one thing I think may be an advantage of having a neurointerventional do it, that you can maybe pick up a mediastinal disease that's outside the neck that may be part of our failed processes in regards to surgical exploration.
We found that jugular venous sampling by the folks over in neuroradiology have given us not great additions to knowledge of the patient's situation. So we've just done this quick, takes 5 minutes really in the office, and it'll at least give you a side. But that procedure is really operator dependent, and oftentimes we've kind of been disappointed.
I gotta be honest, Jeremy, I haven't had great success with this, and maybe I'm speaking for the silent minority here. What is it that you do that your radiologist didn't?
Well, they sample whatever venous structures there are in the neck and give you a value, and it's often kind of confusing. I just do one jugular vein and the other jugular vein on the other side, and at least I get a side, which is helpful.
Yeah, I actually give them a map, and so I want one IJ drawn at the level of the hyoid on both sides, because that's something fluoroscopically you can see. I tell them to get one at the cricoid, which they fluoroscopically can see, and I have them get one very low right at the internal jugular vein junction to the brachiocephalic, and then I have them sample just across the mediastinum. And I think by giving them a map and then showing them exactly where you want them to draw the blood, I've actually had very good success. But I've had very good interventional radiologists that they kind of enjoy this case because no one dies. They're not trying to stop an aneurysm from bleeding or do some other crazy thing. So they've been very good in my experience.
Great. All right, excellent discussion on venous sampling. Jake, why don't you go ahead and proceed?
Sure. So we ended up following this up with a 40 CT. They did note that there were 2 hyper-enhancing central compartment nodules that were both on the right side. There was one in the right paraesophageal region, superior to the right thyroid lobe. This one measured 2 by 6 by 6 millimeters. And then there was a second one overlying the anterior wall of the proximal right subclavian artery at the level of the thoracic inlet. And this one measured 3 by 6 by 7. And I'll run through this, and then I have static images in the following slide. But it should pause. The first one is right here. So here are the static images. This photo over here is the right superior, and then this is the right inferior one that was noted.
Pretty subtle. Kudos to your radiologist.
So just any further questions? Does anyone have thoughts on biopsy with PTH washings of the lesions that were identified on the 40 CT? And then in general, would you offer surgery without a clear target in this revision case? And then if offering surgery, thoughts on how you'd approach it?
Russ, what's your take on doing PTH washings?
I've not found it to be beneficial. And I think the lesions that you presented with are so small, you'd have a really hard time getting a good sample from them. And so I would say that you've got very nice localization. And I think you just realize that this patient's had 4 gland disease from the moment go, and they've just had 1 gland removed and then another gland removed. The other thing that comes to my mind when I see a patient like this and they truly have had parathyroid pathology removed, not normal parathyroid glands, but parathyroid pathology, you do have to worry about rupture of the gland, seeding of the wound, which I think falls into the differential of what may be going on with this patient. Is it that they truly have glands that are just missed, or did they get their wound seeded with a ruptured capsule of a parathyroid adenoma? And so I just put that as something to think about if someone's truly had parathyroid pathology removed. unfortunately, you're going to have a challenging exploration. You've got bilateral disease and someone who's had multiple bilateral surgeries. But it sounds like the patient has symptoms and is a reasonable candidate to offer a surgical intervention for.
Great. Thanks, Russ. And Jeremy, what about question 2? Let's say you struck out on the 4D CT. Would you still offer surgery for such a patient?
Yes, I would, because this patient needs surgery based on symptomatology.
Right, right. Understood. I think that the takeaway is that sometimes the surgical exploration is you'll find things that the scans will miss inevitably when you don't have scans. If the patient has biochemical indications for surgery, then that is oftentimes enough. Okay, Jake, go ahead, please.
So patient in February underwent reoperative parathyroidectomy with bilateral exploration. We started on the right side and did a backdoor approach through the straps to avoid the scar, and then identified a right superior gland that appeared to be slightly enlarged and bulbous. At that point in time, we went to the left side and identified the left superior gland, which appeared completely normal. So a small piece of this was taken for biopsy and then went back to the right side. And overall, this appeared to be disease consistent with a single right superior adenoma, and this was removed. And our intraoperative PTH, our baseline was 224, and then 5, 10, and 15, you can see there was quite a large drop. And our pathology, on the left side, the parathyroid that was identified was confirmed pathologically. That was the biopsy that was done. And then on the right side, this was confirmed to be an enlarged and hypercellular parathyroid. It measured 1.4 by 1 by 0.2 and weighed 0.23 grams. A few days after surgery, the PTH was 8, and the corrected calcium came back in the normal range. And that's it.
Great. Thanks, Jake. Michael, since you were there, could you kind of take us through a little bit of your thought process during the case? Correct me if I'm wrong, but what you found was not necessarily what the 4D CT predicted.
No, so to me, like I said before, re-op cases are to me the threshold for going in those cases is higher just in terms of localization. Um, as I think Jeremy said, though, given the degree of symptoms, I had a very long discussion with the patient and her family about, listen, we can try this. Certainly, there's increased risk of nerve injury, risk theoretically of hypoparathyroidism, but the biggest risk, right, is that I don't cure you. And the other side, the potential upside was significant, right? That if her symptoms were related to this persistent disease, potentially it would have a significant benefit for her. And I said to her beforehand, like, we may get in there and this may or may not be the disease. I have no idea, the ability to recognize glands in a scarred field. Fortunately, I started on that right side and really pretty quickly using that kind of like that backdoor approach that Jake mentioned. It kind of took us right up to that superior gland, and it appeared to me abnormal, but given the relative ease with which that gland kind of revealed itself, I thought, you know what? Let's go to the other side and see if we can find that contralateral superior. Fortunately, we were able to do that, and that gland was clearly normal. And so, that was essentially what kind of led to just taking out that one gland. The one thing I would also just add is that I really very much think of re-op cases as a little bit of a puzzle. And so what I mean by that is you really need to, as best as you can, as in this case and some of the other cases, if you don't have outside records, it becomes very challenging. You're relying on the word of the surgeon, on the reporting of the patient's family, so you don't necessarily have a lot to go on. But you really want to think about what glands probably have been removed, were likely removed. And so, based off of the reporting and based off of the fact that an inferior gland was removed at the second case, um, the glands that are less likely to be found by someone who I think is probably just a less experienced parathyroid surgeon, the glands that are most likely to be found are going to be the inferior glands. it's going to be the superior glands that are more likely going to have not been identified during the case. And so that also influenced just my thinking about kind of which glands probably we're going to be thinking about finding in this case.
Tell us a little more about this backdoor approach, Michael. It's almost like you have magic fingers, but what is it about the backdoor strap approach that so-called led you to the gland? Is there some particular technique to it?
No, it's essentially, going, by the way, this is a very helpful in reoperative surgery, additionally for kind of re-op thyroid cases like re-op central necks and whatever else, which is the plane that is going to be the most scarred in these cases is the strap muscle onto the thyroid. So if you can find a plane between the strap muscles, that plane is usually has not been explored, hasn't been opened up, and oftentimes is scar-free. And if you just trace that out laterally, you go between those strap muscles, that leads you then to the carotid sheath. And that carotid sheath oftentimes kind of, you can then work from lateral to medial. And again, less likely to encounter scar tissue. And honestly, it sets the depth for you in a very helpful way, particularly for superior parathyroid glands.
Thanks. We have a question,
So-
Russ. I'm
Oh,
not sure. Go ahead.
I just want to make I think Michael made a great point about the superior glands, because I think the other aspect of it is that we can unroof a superior gland that looks normal, but the adenoma actually sets on the back side of it and gets tucked in behind the esophagus. And I think occasionally people are a little anxious to completely mobilize that gland because they don't want to devascularize it. And you end up seeing what looks like a normal cap, but you don't look all the way behind. And I think those are frequently that missed gland, is that you even may see it, but you just don't trust that it looks abnormal, and you don't take the time to completely mobilize it because you don't want to run the risk of devascularization.
Yeah, it's a good technical tip. I've noticed that myself. Last question, Jeremy, would you be able to answer the question in the chat about medical management with Sensipar? Have you ever recommended it? Pros and cons.
Yes. Well, the cons are that it's very expensive. It's about $1,500 or $1,600 Canadian for a month, which is about $1.50 American. But anyway, it's very expensive. The other thing is, I've had a long talk with John Belzikian about this years ago, and we still don't know what the long-term effects of Sensipar are going forward. And but I've used it for intractable cases where it's virtually impossible to find the disease, where also a patient with real bad renal hyperparathyroidism that's got multiple comorbidities and it's had multiple surgical procedures. I think there's a place for it there. May I make another comment about surgery? I've approached these cases and I find it's very helpful to, and I've presented this at World Congress, it's very helpful for better exposure to cut all the straps right across and reflect them superiorly and inferiorly. And that displays the whole central compartment very nicely and doesn't give you a keyhole to operate through. I find that very helpful, and you can just suture them up at the end and patients have a normal neck without any tugging of the trachea. The second thing I'd like to ask is, I told you I'm bad at math. I think there were 3 parathyroids that were diseased parathyroids that were removed in this case. Am I wrong on that?
So
or right?
There was 3 that there had been 2 removed in prior surgeries. I personally don't think that those were diseased. I mean, the patient showed no improvement in their hypercalcemia afterwards. And so I think that essentially what were removed were 2 normal glands. And in fact, I think this represented single gland parathyroid disease.
Okay, in the event, just for discussion, in the event that those other 2 were parathyroid diseased glands, and the one you removed, Michael, was diseased gland, you can be sure as shooting that last one you thought was normal at one point is going to turn bad.
Yep.
So would you have given consideration to removing that and maybe cutting off a little bit of it or putting the whole thing into a pocket into the pectoralis for function and future reference if it goes bad?
Yeah, I mean, generally my approach for four-gland hyperplasia in general is a subtotal, taking out 3.25, maybe 40%, something like that. I don't do totals with reimplantation. I'm talking now for primary disease, not for renal disease, but for primary disease, I do subtotals. In this patient, I think given her life expectancy, and her overall situation, I think the likelihood that she's going to develop the disease again, if say I leave behind a significant chunk, is unlikely, but definitely there. So what I did was and this wasn't the case in her, but I would take a little bit of it, make sure it's vascularized, mark it very clearly with vascular clips and maybe a Prolene stitch, and then leave it behind. I personally, in primary patients, I really don't like the idea of doing a total parathyroidectomy with reimplantation.
Yeah, so if the fourth gland that one has left, not saying in this case, but
yeah,
that might have turned into hyperplasia again, if you have to go back in there, I would submit perhaps it'd be better just to take the thing out and reimplant it in a better accessible area. And my area of choice would be infraclavicular into the pectoralis muscle. I've tried in the forearm, and then when those go bad, our friendly orthopod causes some hand dysfunction when he tries to take it out. So I like the pectoralis.
I would just say, Jeremy, that your comment is very well taken, and particularly is relevant, at least in my experience, in MEN patients. Those are a real challenge in that regard.
Great. Well, thanks everybody for an excellent discussion. Caitlin, Alexa, Jake, thank you for your excellent presentations. Michael, Mary, Paul, thank you for your mentorship. And then again, Jeremy and Russ, thank you again for your excellent expertise. All good things must come to an end. I'm going to hand it back to Michael. Back to you. Thank you very much. Michael, you're unmuted, but we can't hear you.
All right, I'll try a speaker. Sorry about that.
There you go.
Yeah, apologize. So yeah, thank you all. Great session. Really a lot of great learning points. At least not only did we learn how to do these surgeries better, but we certainly know where to send people when they run into problems. So appreciate you all being a part of this. Just a reminder to the fellows, our next session will be in 2 weeks. As you recall, we had the conflict with the robot course and the Skull Base Society meeting. So the next session will be on multidisciplinary management of sinonasal malignancies and skull-based tumors. Really excited for that session as well. Can't thank you all enough for taking the time to help our fellows with their education. Appreciate you being a part of this. Have a great night.
Thanks, Michael. Take it easy, guys.
Thank you.
Good night, everyone.
Bye.